Hello, everyone. Welcome to our CAP webinar. Today's topic is on suicide and self-harm. And we've got today two wonderful faculty, the privilege of introducing Shelly Nakaishi, who is a certified pediatric nurse practitioner and a pediatric primary care mental health specialist at UCSF Children's Hospital of Oakland, where she's worked for the past 15 years or more, providing comprehensive psychiatric evaluations and treatment for children and youth in mostly a primary care setting. Shelly also serves as a project coordinator consultant for HRSA FQHC Behavioral Health Integration Grant and is an adjunct clinical professor at the UCSF School of Nursing. We are also very lucky to have with us Dr. Hohui Wang, who is a child and adolescent psychiatrist in the Division of Mental Health and Child Development at the UCSF Children's Hospital, Oakland. She's also an assistant professor of psychiatry in the UCSF Department of Psychiatry and Behavioral Sciences. She's one of our psychiatric consultants on the CAP lines that some of you on this call may have spoken to her in the past, and also provides clinical care in the outpatient clinic at UCSF Children's Hospital, Oakland, as well as UCSF Medical Center at Parnassus Heights. As I mentioned before, today's talk will be on CAP, suicide, and self-harm. We will be taking questions, so please feel free to type in questions into the Q&A portion as they come up, and we'll reserve the last 10 minutes or so for those questions. Please note that this is also being recorded. And with that, I'll turn this over to our speakers.
Hi, so excited to have you all today with us. Thank you for joining us at lunchtime. It's our pleasure. Next slide, please. So neither Shelly or I are involved in the planning or presentation of this activity to disclose any commercial interest, conflict of interest. Next slide, please. Today, Shelly and I are going to first introduce the terminology of self-harm, suicide, and non-suicidal self-injury. And we will talk about the supportive approach to youth with non-suicidal self-injury, followed by suicidal screening, assessment, and management in pediatric primary outpatient setting. And lastly, we prepare a video demonstration on how to do a suicide screening and safety planning and suicide assessment. If we do have enough time after that, then we can do a role play, but most likely we won't have that much time left. So we can also just jump into Q&A. Given that we only have 50 minutes today, we want to focus mostly on the pragmatic part of self-harm assessment and management. Our talk today is not going to be able to cover all the statistics and background information of self-harm and suicide. However, we hope to provide plenty clinical examples and demonstrations and hope that this will help you integrate these practices into your daily practice. Next slide, please. So last Tuesday, Surgeon General actually warned youth mental health crisis in the United States, including surge in number of suicide in children and teenagers in the context of the COVID pandemic. Suicide and self-harm are serious issues, and all of us can feel confused and overwhelmed by managing this disorder with limited resources. Learning about self-harm is identifiable, preventable, and treatable help us grow confidence in making suicide assessment and safety plan, which makes a difference for our patient's life. We found these practices help primary care providers to successfully detect and manage self-harming behaviors. As you all might have known already, PCP acts a crucial role in suicide prevention. Among people who died of suicide, 80% have visited primary care providers in the previous year. On the right side of the slide, you can see that suicide is the fifth leading cause of death among younger children from 5 to 12-year-old in the US, and it jumped up to the second leading cause of death among older teens and young adults. If we look at the right lower part of the graph of the slide, it shows that suicide is a continuum of thoughts, plans, and actions. It is not a cross-sectional phenomenon that happens all within a second. Among 10 million people who have serious suicidal ideation, only a third of them had made a plan, and less than half of them had attempted suicide. Down the line, less than 0.5% among those who had serious suicidal thoughts died by suicide. This tells us that there is a space and time for us to provide interventions before it gets to the final step of someone kill themselves. Next slide, please. So here I want to talk a little bit about the beliefs, biases, and blind spots. All of us have our own beliefs, biases, and blind spots almost to everything, especially when it comes to suicide. Is suicide preventable? Can providers or caregivers really help anyone who's cutting themselves? There is such limited access to mental health resources, especially for suicide treatment. And some people also believe if we talk more about suicide with patients, we may cause it. We may cause these self-harming behaviors. Since we all have our own blind spots, consultation and team support is critical. I would emphasize the importance of regularly checking in with ourselves and checking in with our colleagues about our feelings and struggles with challenging patients. We have been battling COVID and surging mental health issues for almost 2 years now. Burnout has existed before COVID-19, and right now we're working on so many more serious issues, including managing patients' self-harm behaviors. And that can sometimes lead to feelings of worsening exhaustion and burnout. In terms of belief of suicide prevention and assessment, I want to share what I believe in. If we believe that little can be done, then likely little can be done. If it is known that we can make a difference, then it inspires it to be done. Suicide is definitely identifiable, preventable, and treatable if we can have a teamwork. And zero suicide is a plausible goal. There have also been randomized control trials showing that connectiveness between a provider or a caregiver and the patient can prevent future suicide. Next slide, please. Next slide, please. We're gonna introduce a non-suicidal self-injury. So what is self-harm? Self-harm is basically we can divide it roughly into non-suicidal self-injury and suicide based on the intent. So for someone who doesn't have any intent of killing themselves, then that's what we call non-suicidal self-injury. And with those people who harm themselves with the intent of dying, of death, then that's suicide. Non-suicidal self-injury is the most common among adolescents and young adults. Lifetime rates in these populations are about 15 to 20%, so they're fairly common, and the onset age usually occurred around 13 to 14 years old, so slightly before high school starts. Self-harm is a self-directed and deliberate behavior that results in injury that doesn't cause death. What's complicated is self-harm can either be comorbid with suicide or not. So sometimes our patients who engages in non-suicidal self-injury, they may also have suicidal ideation and suicidal behaviors, and that's something that we need to deal with separately. Self-harm, non-suicidal self-injury often comorbid with psychiatric disorders. So the most common ones are anxiety, depression, trauma, especially for someone who have physical or sexual trauma at a young age, eating disorder, substance use disorder, and borderline personality disorder. So this all may complicate the picture that we see when we meet with the patient in the clinic. The comorbidity with suicidal ideation and behaviors, and the comorbidities of many different types of psychiatric disorders. Next slide, please. When we see someone with non-suicidal self-injurious behaviors, the first thing is to figure out the intent, whether there's an intent to die or not. The next step will be figuring out the functions and the methods that they use. We often assume self-harm is for attention seeking, but the biggest reason is actually for emotional regulation. As you can see, 41% of patients use non-suicidal self-injurious behaviors such as cutting or scratching to regulate their difficult emotions or to induce a positive, pleasurable feeling from challenging life that they're dealing with. People can also use that to escape from negative, unwanted thoughts or feelings, or do it as a self-punishment because they don't have better other coping skills. Fewer people use that as a way to communicate how distressed they are. And you can see on the bottom that 21% of people cut themselves or self-harm because there's a peer influence. in the research that I read recently, there are over 16 different ways of harming one person, oneself. So the most common way is cutting and scratching, cutting with razor, sharps, scissors, knives. And there are other many different ways, including self-burning with fire or ice, self-battery, carving self, pinching oneself, biting, banging head, hair pulling, or interfering with wound healing by picking the scab. Next slide, please. So risk factors for non-suicidal self-injury include elevated levels of negative and unpleasant thoughts and feelings. When we see our patients with these behaviors in the clinic, introduce the trauma-informed approach have been very helpful for myself. Since it's often comorbid with different psychiatric disorders, looking at the problem through the trauma-informed lens help the patient to engage better, to build a better rapport with the clinician. Being transparent, direct, and empathetic can really make a difference. I also try my best to clarify confidentiality on the first visit. Note that while we're doing it via telehealth, it's important to acquire the patient's location and best way of contact. Either it's their phone number or their caregiver's phone number, in case that there's any emergency situation that happens, or you have to disclose or locate the patient's whereabouts, that we have those information. On the right, this is a sentence that I use when I first meet with the patient. I try my best to explain when I will disclose risky behaviors with their caregivers. So this is what I say. I will use my best judgment to involve your parents if I feel you're at risk of hurting yourself or being hurt, either by using substances, self-harm, or killing yourself. But before telling your parents, we will definitely work together first to find the best way to inform them. So by saying this, we offer the youth voice and choice, because when the time comes, I want them to know that I will definitely let them know first. So we figure out a way whether we inform the parents together, they choose to inform their own parents on their own, or I inform their parents if that's what the youth wants. Next slide, please. So after we identify and understand the background of non-suicidal self-injury, understand better about the intention, the methods they use, and the function that the injurious behavior serves, next step is to have a harm reduction approach to the teenager. I will use direct, non-judgmental questions to get more details and understand how they feel about these behaviors. We will need to make a safety plan together as well, just like what we would do for suicidal patients. Shelly will go over the details of suicidal assessment and safety plan, which could be pretty similar with what we do for patients who engage in self-injurious behaviors. And after the safety plan, means reduction and parent education are also part of the treatment and management. So we want to eventually be able to work with the teenager to find a way together to involve their parents, because study shows that teenagers who have their parents to be involved as part of the plan actually has better outcome in terms of their safety. This is a website that I highly recommend, and I personally have used it so many times with my own patients. Cornell University has a self-injury study center. They put together a lot of really, really useful and easy to read handouts to clinicians, to parents, to patient themselves, including educational pieces and also sentences to use, either for a clinician or for a parent. So here's an excerpt that we took from the website. Here's some questions that you can consider using, or the parents can consider using. Tell me how this works for you, how this is to understand the function, and why would the teenager want to hurt themselves? What, when, how often, where do you self-harm? And usually, how did it start? What was the trigger? And what were you feeling when you were doing it, when you were scratching yourself or cutting yourself in the moment? How do you keep it clean, safe? Because you want to make sure that their medical needs are met too, that their wounds are assessed and then they're not causing severe infection. More of these questions are included in our handouts. There's also a link that you can click on in the handout to go directly to the website for more information. But these wonderful sentences are what I often adopt in my own clinic. Next slide, please. So when it comes to non-suicidal self-injury, there are so many gray areas, and it can often feel really tricky, especially when do we involve parents. The timing can be hard to gauge, and that's why sometimes it feels so difficult to approach this problem and this population. Informing parents and how to approach removing means, if I do without permission, this might cause more barriers and problems to the patient. Parents' approach is a big factor in treatment and patient's outcome, as I mentioned earlier. So this is how I would do it. So I would look out for red flags. If the patient has higher frequency of self-harm, if the method that they use are highly lethal, if there is a higher medical risk because of their other comorbid medical conditions, and if the patient is also comorbid with suicide, if they're also engaged in suicidal ideation and suicidal behaviors other than NSSI, and if they have other high-risk behaviors or substance use, then I will consider informing the parents right away by working with a teenager still, but I would definitely let them know that this is urgent and I really care much about your safety. And that's what I wanted to be able to work with you, figure out a way whether we can tell their parents together and in what way that we will want to tell your parents together. Vice versa, if the patient engages in infrequent self-injurious behavior, there's little concerns for medical complications. They are very engaged in treatment. They currently don't want their parents to know because they haven't figured out a way that they can comfortable disclose this information. Then that's usually when I would inform parents in a gradual manner, and also still working with a teenager to figure out a way to eventually be able to involve the parents if they still engage in such behaviors. Next slide, please. Actually, about informing the parents, I want to share a personal experience. Sorry, if we could go back to the last slide, I forgot to mention that. So I had an 11-year-old who had been cutting herself for several months during COVID-19 because she's very distressed by the whole back and forth of going back to school or staying at home again. She agreed with me telling the parents about the self-harm, but it is interesting, the week after I told her parents, the patient actually became more irritable and she was pretty mad stepping into my clinic. What I did was I informed the parents and I shared the handout on Cornell website, and I went over the handout in that visit. So the parents actually told me in the following visit that they were freaking out. They're really, really anxious and have thought about all scary things that could potentially happen. They couldn't believe and trust their daughter anymore. So they demanded her to journal her thoughts and level of self-injurious thoughts and behaviors every day, and demanded direct access to her diary. So the patient was basically forced to document her thoughts and feelings and had to let the parents read it every night. Otherwise, the parents will just do the room sweep or raid her room for sharps every single day. So the parents read some information from the handout, and we did go over the handout together. What really happens in clinic is parents have so little experiences with this, and they can really think of the most horrible and scary things that most likely is not going to happen. But because of that scary thought and fear to potential suicide, they would sometimes act very differently, and that may not be helpful to the patient. So what I learned from the experience is I would usually educate parents over a few sessions, because I realized that in one visit, they may not still understand the approach is to not be shaming the patient and really try to be empathetic, empowering them, offering them voice and choice. And often parents can easily forget about this when they're in a fight or flight mode. Okay, next slide, please. So after our first part of non-suicidal self-injury, we're going to then switch the gear to talk about suicide. We're gonna first introduce suicide screening and assessment. Next slide, please. So for suicide screening and assessment, there are a few tools that we highly recommend. For the screening, you might have heard of ASQ, the suicide screening questionnaires that are now regularly used in many emergency rooms in the hospital, and also the Columbia Suicide Severity Rating Scale for primary care, CSSRS. These are both free and both very well made. We're going to use the CSSRS for our video demonstration today because it is nicely designed in a way that it incorporates the risk stratification scale. So it helps to stratify patients into low, moderate, and high risk so that we have a clear idea in terms of the acuity. For suicide assessments, we recommend using CSSRS and SAFE-T, which Shelly will talk about in later slides. We are often, as PCP, we're not the only person who does the suicide assessment. So after you send the patients to appropriate disposition, the crisis team will often, they will implement an even more detailed version of suicide assessment that could include collaborative assessment and management of suicidality CAMS, which is a tool for assessment and also for treatment, and also Linehan's LRAMP, which is part of the dialectical behavioral therapy. You may see on the left side, we also included depression screen here. Depression screening is not valid for detecting suicide, but we recommend doing it regularly with your patient just because understanding the severity of patients' ongoing depression symptoms is helpful in determining their risk. And it helps, it's an important piece when we conduct the suicide assessment. Next slide, please. So here is this example. This is a template for CSSRS, which we'll use in the video demonstration that we're going to play in just a few minutes. So there are 6 questions, and you can see it's color coded. Yellow color means low risk. Orange color means moderate risk. And next slide, please. And red colors indicate high risk. So if your patient answers yes to these questions, then it will tell you where to put the patient's risk level at, and then helps to determine whether this patient is safe to go home or needs needs a suicide assessment safety plan right now, and or whether they need to be sent to the emergency room. Next slide, please. So here I'm going to hand it over to Shelly, who's going to take us through learning how to do the safety assessment.
Just got to unmute myself. Thanks, Eileen. This is the SAMHSA pocket card. It's called the SAFE-T, and it's used for mental and medical health professionals for suicide assessments. And it breaks it down into 5 steps. The first step is to identify risk factors. And in the CAP handout that we have on the that we'll make sure you get, it identifies a set of risk factors. Joanne, can you hit the space bar or move it forward? Okay, thank you. So some of the key risk factors are feelings of isolation, feeling like a burden, a recent loss or breakup, increasing substance use. And then the second step is to gather protective factors. If you can, most of which are actually obtained in your HEADS or SHADES assessment, and as well as in your safety plan assessment, which I'll discuss next. The key protective factors really are about feeling connected to peers, families, pets, activities, groups. What's also important to note is that there's not one single risk or protective factor that predicts suicide attempts, and also that risk levels can decrease and increase over time. The third step is your actual suicide inquiry, which is mostly obtained from your the Columbia Suicide Severity Rating Scale. But I also like to put on the hat of old carts, my detective hat, and think about when is the onset of the suicidal ideation? Where does this young person often start to feel suicidal? Is it right before bedtime? How long does it last? What are their characteristics, aggravating factors, relieving factors, treatments that they've tried, and the severity, and including the severity and lethality of their plan and access to resources to carry out. The fourth step is then to identify and document actually the risk level for suicide. And it's really based on balancing out your risk and protective factors and the severity of suicidality in the plan. And then the safety kind of gives you a brief outline of what would the interventions be related to the risk. And all of this is kind of tying together as well as what the Columbia Suicide Severity Rating Scale is doing color coding as well. The fifth step is to actually document exactly what we just obtained: the risk factors, protective factors, your suicidal inquiry, your actual suicide risk, clearly documenting low, moderate, or high, and the interventions you plan and safety plan that you plan to do. Also, who you've communicated their suicidal thinking to, which parent, and how you did that. We actually have a outline sample documentation tablet. I do have a smart phrase in our Epic that kind of walks through exactly these 5 points. Okay, next slide, please. The main parts of a safety plan are to identify the triggers to suicidal thinking, your current coping strategies, the personal and professional supports for the youth, reviewing the suicide hotline and crisis phone numbers, and means reduction in the treatment plan. But by completing the treatment plan, it really helps me determine the suicidal risk level. Because if a youth has minimal coping strategies and supports, you are more likely to increase the suicide risk and interventions needed. I also complete the safety plan alone with the youth and review it in detail with the caregiver and the youth. And a trauma-informed approach, as Eileen mentioned, is to give the youth the choice of how they'd like to disclose and discuss the safety plan. And as we bring it up to the parents. I also try to avoid using the word safety contract, which may lead to a false sense of security. What I do like to ask for is a specific commitment, like being safe until the next follow-up appointment with myself or with their therapist, or for the parents to remove specific items from the house. And the key part of safety planning, and the one that can save lives, is means reduction. Once you've identified what they may potentially use in their suicide plan, you can address what items and things need to be removed or restricted. And with Zoom visits, I've actually been able to see what and where items are stored, and then problem solve with the youth, and then do this again with the parents, and actually verify that it has been done. I've also learned the importance of documenting the safety plan and the specific means reduction plan. In one case, the CPS had asked for this information after the second suicide attempt for a youth who had overdosed on her medications, and after we had asked the mom to lock the medications up. And this was a special case in that the mom also had mental health conditions. And once CPS was involved, they actually did help mom receive more services. A little bit more about means reduction. Suicide attempts actually typically happen in the first 10 minutes of suicidal thought. So creating distance can really help save lives. And about 85% of attempts that are done with the firearm are fatal. So if we can restrict access to guns, we can save lives. There's a really great means reduction website that has great handouts for parents around gun safety, for providers on how to talk about gun safety. One of the approach that they talked about is, this is the quote they said, what some families in your situation do is store their guns away from home until the person is feeling better. For example, with a relative or a gun shop or self-storage rental. And if you do have guns at home, I'm wondering if you thought about a strategy like that. Here, where they're not questioning the decision to have guns, we're simply asking and addressing a short-term storage option. And the other thing is to be sure to assess each relevant household that a patient may live or visit around means reduction. And so now, how do we keep the safety plan that's easily accessible? There is a My3 app that's free and can be downloaded, or you can simply write the safety plan out and then take a picture of it on the phone. So next slide. A lot on safety planning, but it's critical. This is just the outline that Eileen covered. If you take the Columbia Suicide Severity Screening color coding, this is how we've built an algorithm around suicide screening. So yellow indicating low risk, orange and red indicating more moderate to high, and involvement of a behavioral health consultation. So we're going to go through these a little bit more in detail. So next slide. The low risk yellow is by using the safety suicide assessment and the screener for suicide, if there are modifiable risk factors and strong protective factors with some suicidal ideation, but no plan, no intent, and no behaviors, this is the case for active monitoring, having them come back weekly, maybe targeting some of their key symptoms like trouble with sleep, consideration for depression treatment, and referral to behavioral health, and of course, the completion of the safety plan. Okay, next slide, please. This is where we start to move into the orange, moderate. And this is the moderate risk is based on multiple risk factors identified, few protective factors, and there's actually a suicidal plan with no intent, though, and no suicidal behaviors. After you've done the safety plan, you can determine how soon you'll need to have the patient seen by a behavioral health provider, whether it's the same day, next week. And this is also a time where you're like, I can't find a therapist. They don't have a therapist, but they really want a therapist. This is where I've been in this situation myself, where I just get on and I call the county access phone numbers, and with the permission of the patient, and telling them what I'm doing, and then I will be informing them of the suicidal ideation. This is when they are much more able to get us a therapist quickly when we're calling with the suicidal risk. We do know that caring contacts has been found to be effective in reducing suicidality. So your telephone calls and your follow-up appointments and checking in do make a difference. Okay, next slide. This is the high severity, and this is when a patient is at a high suicide risk, and when there's major mental health issues, and there is acute precipitating event, like a recent breakup, and the patient has a suicide plan that is potentially lethal, and there is persistent ideation and strong intent or some suicidal behaviors. And this is when you are going to enact your clinic's psychiatric crisis procedure. And in our office, we call it a code gray. This is where we have the front office involving, they're calling security for us, they're coordinating with their other patients, and calling the ambulance if needed. They're helping us coordinate with the on-call provider who's providing us consultation. And we're also making sure that the patient is never left alone. Next slide, please. So the beauty of having a clinic procedure, when you're in a crisis, our thinking brain is less active. And that's why it is wise to have like a procedure in place. And it should be team-based to help reduce anxiety and ensure safety. And as mentioned earlier, in our office, we call it Code Gray. It actually does cover the psychiatric crisis for suicidal, homicidal, or extremely agitated, volatile behaviors. And it, of course, covers how we involve security, the on-call support, mobile crisis or police involvement, where we'll meet the ambulance and who coordinates that, who can help us manage the other patients in the clinic. And we also, every time we have a code gray, we review and update it after each code. Next slide, please. Just as we are familiar that if someone is having an acute medical crisis, we send them to the emergency room to be further evaluated. And we have the same for a mental health crisis. So if you can hit the space bar, great, thank you. This is the same education I provide to patients and families when we walk through the steps of what will happen next for a mental health crisis. And a psychiatric crisis evaluation for under 18 is called 5585, and over 18 is 5150. But for now, I'm just going to keep using 5150 for the rest of this discussion. And if you start at the top red block, well, if we're in an outpatient setting, it could be primary care, pediatric primary care, it could be a neurology clinic, and there's a suicidal patient that needs further evaluation. In our county, the police or mobile crisis are called to come in to write a 5150 transport hold to a designated facility, which could be an emergency room, a crisis stabilization unit, or psychiatric hospital. And this designated facility has 72 hours to evaluate if this patient will actually be psychiatrically hospitalized or if they can be safety planned home with supports and referrals. And so this is the 5150 evaluation. And a key point here is that the primary care provider, if you have them get taken to the designated facility, you are sending them to the facility to do the 5150 evaluation, and they make the final decision. Very often, patients are actually not psychiatrically hospitalized, but they can be connected to more resources, and they might have like an aftercare program that monitors them. And each county is different. One thing that is helpful for patients and families is to explain the process of what's happening and if the police are going to be involved or an ambulance and what it might feel like and look at the designated facility where the evaluation is being done. And it's also really helpful to call the designated facility ahead of time before the patient gets there to give them key information, like if there's any mental or medical health diagnoses like autism, if they're taking any current psychiatric medications, and what is this suicidal concern, if there's been past suicide attempts or hospitalizations, and other major risk factors. And of note, though, this is also the same type of information that would be helpful if you're calling in the crisis team. You'll want to provide this key information to them as well. Next slide, please. Okay, so psychiatric hospitalization. There's actually no validated criteria available to guide us as providers in assessing in outpatient, assessing the level of risk for subsequent suicide and determining the level of care that's needed. However, it's generally agreed that the criteria for immediate referral for an inpatient psychiatric admission is if the youth has a continued desire to die, severe hopelessness, ongoing agitation, increased inability to engage in safety planning, inadequate support, or able to follow up, high lethality attempt or attempt with clear expectations of death. And those who are very averse to psychiatric hospitalization, getting hospitalized can actually reduce the likelihood of future suicidal behaviors. There's no data actually showing that hospitalization reduces risk or prevents eventual suicide. And the downsides is hospitalization may increase long-term risk due to increased stigmatization, isolation, decreased self-esteem, negative impact on the therapeutic alliance, possible financial burden or missed work or school, and in some cases, a reinforcement of suicidal behaviors when the hospitalization feels like more it's a positive situation for them and they don't mind going back. Okay, next slide, please. So what treatment, and if you hit the space bar, is available for suicidal behaviors and non-suicidal self-injurious behaviors? There are some specific therapeutic suicide-focused treatments, and many of these treatments are used by individual therapists, mobile crisis, intensive outpatient therapy, partial day hospitalization, psychiatric hospitals, and residential facilities. And I know we're gonna get a bunch of questions of like, but we can't get anyone in. That could be a whole nother lecture. So next slide, Joanne. All right, so this is the yo-yo, the balancing dance. The self-harm discussion with youth is very much this yo-yo balancing effort of really actively engaging the patient and trying to find a balance between being direct while also maintaining connection. by being able to be empathetic, validating, reflective, along with really being a detective and assessing for risk and safety. When asking specifically about suicide, it's really best to approach the behavior or thinking directly, invoking a neutral perspective and using the appropriate suicide terminology without an editorial bias to strip away any stigmas or feelings about the situation. While empathy is really important, it's critical to avoid loading the situation with our own additional feelings, fears, or opinions about suicide. And one example is if we ask a patient if they have any feelings of hurting themselves, but they may not want to hurt themselves because they don't like pain, but they may have feelings of wanting to die or to kill themselves. And a term to avoid saying is suicide gesture, which could be associated with dismissive connotations. And another term to use is died of suicide rather than committed suicide. So the more we practice and say these words out loud, like suicide attempt, the less stigmatizing it is and the more comfortable we feel. And then this will hopefully help the youth feel more comfortable as well. And so in order to do that, we're going to demonstrate now the completion of a Columbia Suicide Severity Rating Scale and Suicide Assessment and Safety Plan, which can be done in 12 minutes, 13 minutes, hopefully.
Hi,
so much to say, so little time.
It is nice to see you once again.
It's nice seeing you too, Dr. Wang.
Before we start for this telehealth visit, I'll need to confirm your consent to do this visit via video and informed you that this is not being recorded. Do you agree to the video visit?
Yes, I do.
Great. Also, what is your current location and phone number, and who is with you in that location?
I'm at 5275 Claremont Avenue, Oakland, 510-428-3571. And my mom is next door in the other room.
Okay, good. For the first part of this visit, are you able to talk in private? No one else is able to hear our discussions?
Yeah, my room's closed.
Okay. And also, is this your mom's current phone number, 510-428-3344?
Yeah.
Shelly, thank you for your patience with all these logistics. We ask these questions in case we get disconnected and if there are any safety emergencies. As always, I would like to review the confidentiality rules of this visit. I will keep our discussions in confidential and using my best judgment to inform others for your safety. For example, I would inform your mom and others if someone is hurting you, you are hurting yourself or plan to hurt yourself, or you have plans to hurt someone. I would not inform your caregivers without your knowledge, and we will work together to find a way to involve your mom if needed. Any questions or concerns around these rules?
No.
Okay, good. So now that we have covered your main concern for stomach aches, I can also see that you have completed the depression screening and wanted to spend the last 10 minutes checking in on your mood and feelings. Often when a young person is feeling depressed and sad, there can also be feelings of wanting to die. I see that it indicated some feelings of suicidal ideation. Is that correct?
Yeah. Are you looking at my PHQ-9?
Yeah. We were reviewing your PHQ-9 and thank you for sharing all these feelings with us. It sounds like you have been dealing with a lot of pain. I would also like to use a screener to help access more about your suicidal thoughts. It can be difficult to talk about these feelings. And it's also an important thing to ask and talk about them because we do want to keep you safe and want to find ways to help you. Here are some screener questions. Have you wished you're dead or wish you could go to sleep and not wake up?
Yeah. Ever since my breakup, I've just been really sad and crying all the time.
I'm sorry to hear that. Breakup can be really painful. Have you had any actual thoughts of killing yourself?
I guess so, like in the last few weeks, a few times last week.
Mm. Have you been thinking about how you might do this?
I don't really like pain so much, so probably like overdosing and taking some pills.
I see. Have you had these thoughts and had some intention of acting on them?
No, I've just been thinking about it.
Okay. Have you started to work out the plan or worked out on the details of how you would kill yourself? Do you intend to carry out the plan?
Not really. Sometimes I know we have some Benadryl somewhere, And maybe if I took that, I'd just go to sleep and not wake up. But I haven't had any actual intention on doing this.
Hmm. Have you ever done anything, started to do anything, or prepared to do anything to end your life? Things like writing a goodbye note or finding the Benadryl bottle.
No, I mean, I don't really want to kill myself. I just hate feeling this way.
Thank you for answering all these questions. And it does sound like you have been dealing with a lot of stress and painful feelings.
Yeah, it's been really, really hard. I don't know who I can really talk to really, and
Mhm.
I don't want to freak my mom out, so I just keep telling her I'm okay.
Yeah, Shelly, these can be really hard things to talk about. It is really brave of you to talk about your feelings here with me. Just as someone who has any physical pain, we make a treatment plan for them. For emotional pain, we make a safety plan, which includes connecting you to therapy services. Would you be willing to talk to a therapist? Would that be something that you're interested?
Yeah, I think that would be a good idea.
Great. And we can talk more about the details later. Now we're going to make a safety plan together. What are the warning signs that you notice when you start feeling suicidal?
I start to cry a lot. I feel really alone.
I see. And what kind of things were who motivates you to stay alive, to keep going?
Uh, really, what's like my pet dog and my mom.
Oh, it's always really nice to have these supports. What are some of the ways you cope or things that other people can do for you to help you through these crisis moments?
I guess it's talking to like my best friend, maybe my mom. I distract myself a lot by watching like uh, Netflix or TikTok videos, and
Mhm.
sometimes I might go for a run and exercise.
That's great. You're very creative and you have some really good coping skills. Um, who do you call for support? Who do you feel connected with at school, at home, or in the community?
Uh, my best friend, of course.
Mhm.
I think my aunt a lot. She's always there for me, and then my mom. And there's one teacher at school I feel pretty connected to.
That's good. You have a lot of good people in your life. We're gonna write down their names and their phone numbers so that you can contact them when you're in crisis moments. Um, are there any professional supports like school counselors or organizations you have found supportive?
No, not really.
Okay. In this plan, I will provide you some numbers, including the National Suicide Hotline number and crisis phone numbers to call. Many of them are confidential and they're open at all hours. Would you be willing to commit to calling them if you're unable to contact any of your personal supports?
Yeah, those would be good to have.
Great. And what can we do to make your home and other places safe for you? Like making sure that you don't have access to medications.
I'm not really sure.
Okay. We can also discuss this with your mom. So now that we have completed a safety plan together, we will need to share this with your mom too. I wanted to ask you, how would you like to discuss this with her? Should I bring this up or would you like to do it?
Can you bring it up with her?
Yeah, of course. Can you bring your mom into room to discuss
Yeah,
this
I'm
about
gonna,
this?
I'm gonna go get her. I'll see if she's available. Hey, Mom, are you ready? Yeah. Can you join the doctor visit? Of course. Of course, darling. Okay, here's my mom.
Hi.
Of
Hi, Mom. Thank you for joining us.
course.
Shelly has been very brave this morning in discussing some difficult feelings. We want to share with you that she has been feeling depressed in the last month, and she has been having some suicidal thinking at times. Shelly does not have a plan, and she has not had any actual suicide attempts. She's great, very creative, very motivated to seek out help, and is ready to work with a therapist. Our goal now is to have a shared safety plan so that we can keep Shelly safe.
Shelly, I knew you were feeling sad after the breakup, but I'm surprised to hear that you're suicidal. I wish you would have let me know so I can be more supportive.
I know, Mom. I was just scared.
Yeah, it can be very challenging to bring it up for the first time. What we do know to protect Shelly is to develop a safety plan together and to connect her to mental health resources. We've already started the safety plan earlier, but the key is really to review it together as a team, and then review her triggers, coping skills, and supports. You can see the safety plan here. And mom, I just wanted to see if there's any additional supports they can add to this list.
I know she's really close to her auntie.
Yeah,
Mhm.
I listed her.
Oh, you did? Oh, Shelly, I'm so glad you listed her.
Yeah. Um, the other thing is one of the key coping skills is to be able to talk to you when she feels suicidal. So that's one thing that we noted when we're creating the safety plan. Let's go over some other ways on how you can also help Shelly feel safe. One thing is to listen to her feelings, validate her feelings in the moment. You can say something like, that sounds so hard, that sounds so painful. And a lot of parents want to be helpful. They jump into problem solving, but it can also make the teenager feel not being supported. So the other thing they can say is to thank her for telling you about her feelings. You can also tell her that you're here for her and here for her to make her feel safe. You can also ask her what might help her in the moment. Some parents would offer things like, do you want to watch a movie together? Do you want to go on a walk together? Do some deep breathing together, remove sharps or any other lethal means for her. It's also important to review the safety plan together when she's in the crisis moments if you feel like it's needed. And lastly, you can also ask if you need to call anyone, either her personal supports or other professional supports if Shelly does not feel safe. You can also call mobile crisis or take her to the nearest emergency room if the situation has been emergent. Part of the safety plan is really to reduce any items that may be harmful for Shelly. So the other thing is for Shelly specifically, this is any medications, including any over-the-counter medications like Benadryl or pain medications. Do you think that you can remove these medications? Some people have a lockbox, like a toolbox they use or a lock closet.
Yeah, I have this file cabinet that I can lock up.
Oh, good. Okay. Where would the keys be?
I'm gonna hide it somewhere.
Okay. Shelly, do you know where your mom hides the keys?
Yes, I do, Mom. I'm sorry. I know you hide it in the top clothes drawer.
Oh, okay. Well, then I'm gonna have to hide it in a new location.
Thank you for being very honest with us, Shelly. We will also ask all family, are there any guns or weapons in the house where if there's anything that Shelly could have access to?
No, none.
Okay. Okay, good. So here we have the safety plan with all the crisis numbers. We also made a follow-up appointments for Shelly next week so that she can check in back with me. And our case manager will call you tomorrow to set up a therapy referral for Shelly. Shelly, do you think that you can come into this appointment next week and reading the safety plan, talking to your mom when you feel suicidal, and using the crisis number if you're not able to reach your mom and you feel suicidal?
Yeah, I can do that.
Good. And mom, can you commit to supporting Shelly when she feels suicidal and helping her to set up therapy?
Absolutely, yes. Yes, sweetheart.
Great. Shelly, how are you feeling now?
I'm feeling better. Just scared. I didn't want to upset my mom.
No, you've done the scariest thing of sharing your feelings. You have been so brave. That is the hardest part. Our job as your provider and for parents is really to help you feel better and to keep you safe. Emotional pain is often hidden. It's not like a broken bone that you can see and just fix it. And just as broken bones can heal with cast, we do have support that can help heal emotional pain. Do you, at this moment, do you feel like you need any other help to keep yourself safe before we meet next time?
No, thanks everyone for being there.
Of course, Shelly. Thank you, doctor. Thank you for letting me know, Shelly.
Yeah. And thank you, Shelly. We would not have time for interactive breakout. And let's jump right into the Q&A. They're having some really great questions, very thoughtful questions, and we try our best to answer as much as we can. We have 3 more minutes. So for people who had seen our responses, if you have follow-up questions, please raise your questions And for anyone else who have additional questions, please feel free to do so as well.
Right now, everyone's on mute. And so just kind of indicate in the chat if you still have a question, if you want to raise yours right now. But also, I want to let you know that the recording will go up onto the CAP website. So look for it in the next few days. We will also try and get their handout up either onto the website or emailed out to all the attendees for today's webinar. And I think that includes a safety plan or a link to a safety plan as well.
It does have a safety plan template.
So it sounds like it might be helpful to just review one more time the clear indications for when you might want to call the ER or call 911.
Can you go back to that slide, Joanne? I mean, it is a tricky thing and nerve-wracking. The Columbia Suicide Severity really tries to give you some indication that if there's really high risk factors, there's acute precipitating event, major loss, a breakup. They have a suicide plan. There's persistent ideation and strong intent. They've actually had some suicidal behaviors, like they posted things online, they started giving things away, they rehearsed it. That's when you're and you've done your safety planning, and they're not able to say they can do any or follow any of these parts of the safety plan. And you're not sure if they would even come back and see you the next day. That's when you need to have them evaluated. And you're correct. If you call and do the procedure, and you have in your county, if the police are the ones that write the transport hold, they also do their own evaluation as well. And so they can decide, yes, they should go or they should not go. But this is where if you've gathered your information in your suicide assessment, you can help provide that information to the officers or mobile crisis to help really weigh in and give your input into the severity of the suicidal thinking.
Thank you. And do we happen to know the crisis number to call? I mean, many of us just call 911 and call the ambulance over. But is there actually a different crisis number that you'd recommend calling?
There are different ones for each county. And so Alameda County has crisis numbers. There's a mobile crisis number as well. And then Berkeley has their own specific mobile crisis. And so does San Francisco. So it's based on counties.
Wonderful. Well, we're at the end of time. Thank you so much, Dr. Wang and Nakaishi, for your fantastic talk. I'm going to be coming to our very last slide here so you can check yourself in. Please use your smartphone, click onto this, train it on this QR code, or else go to this website here in order to check yourself in and claim credit for today. Thank you so much, and hope you have a wonderful holiday.